Good afternoon, everyone. I welcome everyone for the CQE series on quality and safety in diagnostic imaging. So, this is a very important subject towards quality improvement program. With this note, I would like to welcome Dr. Namitha Sinha, the lead consultant radiology Aster Wildfield, Bangalore, to take the first session on quality assurance program in imaging services. Over to you, ma'am.
Thank you so much, Ms. Das. Good afternoon, everyone. I will be talking about quality assurance program in radiology. The basis of quality in imaging is to know that humans can make errors. So to err is human. And what we do with that error and how we improve quality based on that is what is most important. So we build a safer health system. This was a report in 1999 by the Institute of Medicine, where it said that 98,000 Americans die each year as a result of preventable medical error. And the quality chasm is the difference in realizing that improving quality proactively can avoid this kind of error. This is a new health system for the 21st century where everybody is talking about how quality can make a difference to everything. Right? What is quality in radiology? Quality in radiology is the production of timely and accurate radiology reports, which are produced in conditions of maximum patient safety and communicated in a timely manner. So it should be done in a timely manner, it should be reported in a timely manner and communicated in a timely manner. And these reports, not to stress upon it at all, have to be accurate. They have to also be done keeping patient safety in mind. It involves the appropriate use, selection, interpretation, and application of imaging. The American College of Röntgenology defines quality as the extent to which the right procedure is done at the right time and the correct interpretation is accurately and quickly communicated to the patient and referring physician. The goals of quality are to maximize the likelihood of desired health outcomes and to satisfy the patient. So, what is quality in radiology? Based on these definition is quality from acquisition to the reporting. So, the selected modality indication should be based on clinical diagnosis. Not every patient who comes to the hospital requires the same kind of investigation. Also, the kind of investigative modality which we are using can be different. So, we have to select it based on the clinical diagnosis. We should do a radiological examination according to protocols and with the best quality available. And then we should accurately interpret and communicate these results. So quality, if you can't measure it, it doesn't exist. You can't just say we do good quality work. It has to be some measurables for that to prove that you do good quality work. Only once things get measured can they get improved, because everybody would be saying the same thing unless and until you have an objective way of communicating it. So what quality actually means is doing things right when no one is looking. The quality is so imbibed in your system that even when nobody is around, you will be able to do a thing in the right manner. So what is the quality assurance program in radiology? The goals are that while everything is going on, there should be patient and staff safety. There should be compliance to regulatory requirements. We should be able to optimize the image quality. The equipment performance and maintenance should be up to date. There should be compliance to evidence-based practice and accreditation standards. There should be clinical and service excellence. Patient should be happy with the service that you've achieved, but then also what is most important is that the reports that are given should be as accurate as possible. And to ensure all of this is happening correctly and right at the same time, we have to be focusing on staff training and development. We should be complying with legal and statutory requirements. What is the legal requirements and statutory requirements we have? We have the NABH, which lays down the rules for how a radiology department should function. We should standardize the test request forms. When patients are asking for it, when clinicians are asking for the request forms, they should be in a standard manner so that we know what needs to be done. There should be quality control in processing, interpretation, and calibration. The results should be available within a defined turnaround time. Now, if a patient has come with acute abdomen pain and you've picked up appendicitis, but you've conveyed it 3 days later, this is not good quality may be absolutely accurate because the patient's condition would have significantly worsened in that time being. So they should be done within a turnaround time, which is desirable. For emergencies, in radiology, we tend to make sure that the oral communication of report happens within half an hour, and the report is actually being made to release within 1 to 2 hours, because if that patient needs some insurance for any surgeries, those reports can be sent out. Critical results are intimated immediately to the concerned personnel or the clinician. What is critical according to us? Something which requires immediate medical intervention. An informed consent should be taken prior to all kinds of procedures, especially ones which involve radiation, and the infection control in the radiology department should be completely optimal. What do the national accreditation standards state? These are the NABH standards. So it says that testing of imaging equipment, review of imaging protocols, appropriation of investigations, and procedures for clinical indication. There should be peer reviews of the reports that have already been generated. There should be clinical and radiological meetings. There should be calibration and maintenance of equipment. All of these are standards that the NABH has set for us, and that is what we intend to follow in the department. Patients should be screened with radiation safety devices. There should be monitoring devices. There should be radiation safety measures. Patients, young females who come in of reproductive age group, their last menstrual date is always asked to make sure that any unborn fetus is not receiving any radiation. Staff should be trained in how to manage these situations, what to questions to ask, how to make sure that the radiation is least, and appropriate warning and signages are put up across the department. I will not be talking so much about safety and radiology department because I think that is a topic someone else is covering. I'll be talking about the quality assurance program. One should set standards and protocols. So you adopt the national and international guidelines. So not just an NABH, but the American College of Radiology, the AERB guidelines, all of these should be adopted. You should define the quality control processes for each modality. CT, MR, X-ray, ultrasound, both for the machines, for the type of investigation, and for the type of report generated. There should be a process so that everything falls in line. The imaging quality control should regularly assess the quality of the image, including the sharpness, contrast, and noise, and perform phantom testing to evaluate equipment performance. In the radiology department, a QC or a quality check for all equipment is done every 6 months to make sure that everything is functioning properly. The MR and the CTs are actually, phantom tests are run much more often, even once in 2 days, just to make sure that things are functioning properly. Because it would be not good to do a CT and then realize that it is not of optimal quality because you've already radiated the patient by then. Radiation safety measures should be implemented like the ALARA, which is radiation should be as low as reasonably be achievable. And we should ensure dosimeters are used for staff monitoring. We have TLD batches which are used for staff monitoring. The equipment should be calibrated and maintained properly to give a good quality image. So we have to schedule routine preventive maintenance and calibration. And we keep a detailed maintenance log and checklist for all equipment. Apart from all this, the staff who is with us should be trained repeatedly with competency assessments. So because we keep getting newer staff to join in, plus what you have told today may not be valid 3 months down the line in patient's memory, in the staff's memory. So you have to provide regular training sessions on new technologies, on the QA protocols and radiation safety. And you have to conduct annual competency evaluations. We do that. We have MCQs which we circulate amongst our staff to see whether they are absolutely okay to work on the now. These competency evaluations for radiographers are mostly to do with safety and processes, but for our radiologists, we also do MCQs for image interpretation, accuracy, and safety practices, because we maintain that everybody should be learning while they're on the job. What are the quality markers? Radiation dose, how much radiation has been given. Was there a wrong X-ray taken for which a repeat image was required? We have to maintain a register of all the redos that we do, because there we have failed somewhere and we would not want to repeat the same mistake. What is the patient satisfaction? Was the waiting time too long? Did the patient have to wait too long? Did the patient have to wait too long before the investigation? Did the patient have to wait too long during the investigation or after the investigation for a report? All of that is monitored. What is the ease of scheduling? What is the accuracy of interpretation? And then how prompt and clearly the report has been communicated. So the measurables for quality, as I said, are waiting times. As I said, there are two waiting times. One is from when the patient comes to the department till the time the patient's investigation is done, and the other waiting is from that time till the report is generated. Right. So we have uh, waiting times for all of that. We calculate the turnaround times for reports are calculated. As I said, which is the second one. Waiting time is when they came to the department till the time they were billed, and from the time they were billed to the time they were investigated. Reporting errors, we look at all our reports and pick out which are the errors. I'll come to that later. What are the redos, as I said, because if it is a redo in a case of a CT or an X-ray, then we are in a way harming the patient because you are radiating the patient again and again. And what are the discrepancies in the clinical findings and the reports that have been generated? The role of radiologist is not just limited to being able to interpret that the images that have come to us. We all are on PACS. Images come to our systems automatically. However, that is not the only role. We have to supervise the technical aspects of the imaging. So in case a patient is going in and has difficulty swallowing, we have to say that patient should be imaged while the patient is saying E. Patient should be imaged while the patient is swallowing something like oral contrast. So we supervise the technical aspects of the imaging. We have to accurately interpret the imaging studies that have been provided. We have to generate reports of these studies and in which we mention the examination's findings. And we have to be able to communicate these to the referring clinicians, because it just doesn't end with generating the report. The clinician will want to come and see exactly where the lesion is, how big is it, will he be able to operate on it, are the surrounding vessels involved, is there any other involvement, should we wait and actually put in a wire and drain the pus or something like that. All of this we should be able to communicate to the referring clinicians. What are the technical aspects of imaging? So we standardize the protocols for MRI and CT. If it's an MRI brain, we will acquire these 8 sequences. That's standardized protocol. Unless and until patient is very restless and you want to report in a hurry, you will acquire 2 or 3 sequences which you'll customize based on the patient's conditions. If it's a CT of the abdomen where we're suspecting liver lesion, we have to give contrast, acquire images at these fixed intervals. All of that is something which is the technical aspect of imaging, which the radiologist and the radiographers are standardizing protocols for. We do it based on the ALARA principle. So you will say, why should we have such standardized protocols? We can always call back the patient. No, we can't, because all the radiation that is given to the patient should be as low as reasonably be achievable. So we should do a study in a way that this is the complete study and the patient doesn't need to keep coming and going again and again. We should be training our radiographers for the newer sequences that we are getting, for any differences in protocols that happen. We should be training them as to how they should be done. When we get radiographers in the newer ones, we start with x-rays, but we give them exposure to CT and MRI, make sure that they understand what is happening, and then within 2-3 months we start giving them independent control of the machine, all of that in due time, to be able to train them properly. We should do things based on the ACR appropriateness. ACR is the American College of Röntgenology. I-REFER is the UK standards. So what does it mean? It means that when a patient comes with a certain complaint, the imaging study that is done should fit into the what is appropriate for that particular complaint. So if a patient comes with pain abdomen in the, say, right lower abdomen, you're suspecting appendix, and the patient is a young male where you may not be able to see an ultrasound, do an ultrasound, do a CT. However, if a patient comes, same age patient comes with lower abdomen but pain which is also associated with burning while passing urine, in that case you're suspecting a infection of the urinary bladder, you do an ultrasound. So this kind of decision that you make based on what the patient is complaining with has to fit into the I-REFER and ACR appropriateness. And we should always have some subspecialists either within our hospital or people whom we can seek opinion on in case of any expertise utilization. Okay. So right now the biggest problem would be you have an X-ray, you have an X-ray, you have ultrasound, you have you have CT, you have MR. For the abdomen, you can basically do which everything. So, what do you prefer to see, right? So, in this case, what we have to do is find out what investigation would we be doing. Now, this, as I said, depends on what is the clinical suspicion. The ACR appropriateness criteria for emergency imaging, and these have been achieved simply because we want to give good quality care to the patient as quickly as possible. So we can do an ultrasound and then sit on something saying that we are not very sure what the findings are and do a CT about 3 days later. But for that patient, those 3 days are very intolerable because the patient is writhing with pain. So what it says is that in case of all emergency abdominal pathologies, CT scores over ultrasound. So for appendicitis, colics, pancreatitis, postoperative fever, pain abdomen, non-specific pain, all bowel pathology, CT is the imaging modality of choice. Ultrasound is used for calculus cholecystitis. And as I said, for bladder infection, ultrasound can be used. So in adults, a plain CT abdomen should be the first modality of investigation from the emergency department to obtain correct diagnosis in the interest of time. Kids and pregnant ladies should get a USG done first because in kids the radiation dose can get very high, and also in pregnant ladies you would not want to radiate the fetus. So they should get an ultrasound followed by an MRI for limiting the risks of radiation. So this is a case here. You're seeing that there is some hepatic enlargement. Okay, this one had come for an ultrasound and then there was just some gas, kidney was not seen. So patient was said that there's just some hepatomegaly, probably that is the cause for your pain. However, the patient's pain did not come down in 3 days. They did a CT which picked up this kind of gas all around the kidney. So this was basically an emphysematous pyelonephritis. Now, if they had followed the appropriateness condition, which talks about what a good quality image or imaging modality is for every complaint, we would have picked this up 3 days and if before, it may not have been this fulminant, and the patient would definitely not have had pain for these many days. Patient finally had to undergo removal of the kidney. Similarly, another case came with lower abdomen pain. We tried to look for pain for something in the right iliac fossa, could not find the appendix. A CT run 3 days later picked up the appendix, which was going below the liver. So this was an abnormal course, which is subhepatic appendix. If we had done a CT immediately when the patient had come in with pain, then the patient wouldn't have suffered additionally. Thankfully, in this case, the appendix did not rupture, so it was still manageable in the same way. This was a 29-year-old pregnant lady with right iliac fossa pain. We did an ultrasound, could not pick up anything, could not do a CT, but on an MRI, we see the appendix. You're seeing the fetus as well, and you can see the appendicular inflammation. So this was appendicitis. She was operated upon, and she was absolutely fine after that. Again, patient comes with right-sided pain, lower abdomen pain. They were thinking whether appendicitis, sent for ultrasound. We did an ultrasound, picked up hydronephrosis, did not see anything much. When we did a CT after that, we picked up the stones. So remember, for any kind of stones of the kidney, ureter or bladder, CT scores over ultrasound. For appendix, CT scores over ultrasound. For bowel pathologies, CT scores over ultrasound. In all these cases, CT should be the imaging modality of choice. People say, how can we convince them directly to do a CT without doing an ultrasound? What you have to realize that ultrasound, waiting for ultrasound, getting an ultrasound done, saying that nothing is seen, probably let's wait it out. And if the pain persists, do a CT is actually wasting time for both the management of the patient and also it may result in more complications compared to if a CT was done immediately. This is a case where there was left side abdominal pain. Ultrasound just showed excessive gas. And then on CT, you can see there was a bowel pathology. It was a sigmoid volvulus. Okay, so basically, quality of radiology does not just depend on the quality of report. What imaging modality has been chosen to give good quality care to the patient is also a part of quality in radiology. So based on all this, we've come to this, uh, you know, uh, this is a standard process that we follow for all acute abdomen. If it's pediatric, we do an ultrasound. If it's adult male, we do a CT. If it is a female, we do a urine pregnancy test if she is in the reproductive age group. If she is pregnant, we do an ultrasound. If she is not pregnant, we do a CT of the abdomen. And with this, we have picked up a lot more pathologies that we would have picked up either delayed or not picked up, and the patient goes to some other hospital where they say that they do a CT and say that he's missed an appendix on ultrasound, which does not make sense because the CT should have been the modality of choice anyways. This was another case. Young lady came to the hospital, not married. They did a CT anyways because the ultrasound did not reveal much, and there was because an ultrasound could not be done at that time. She was not allowing a transvaginal ultrasound, but it revealed an ectopic pregnancy, a pregnancy which was outside the tubes. So we should do a pregnancy test irrespective of the marital status to make sure that we are not missing out on ectopic pregnancy. Similarly, for trauma also, we should do a CT of both the brain, thorax and abdomen pelvis. So here in this case, when we do a plain study, it may look normal, but when you give contrast, you can see that there is a cut in the liver, which is going all the way outside the capsular level. So it is actually opening out into the pericardium. So this was a major trauma, which was not detected on a plain CT. Again, we waited for some time and then picked up when the hemoglobin started dropping, did a post contrast, which picked up the hepatic laceration, which was extending into the pericardium. Similarly, this was a kid who had come with uh, acute trauma, a vehicular accident. Nothing much was seen on a plain CT. There was some blood, but we were not able to see where it was coming from. When we gave contrast, we realized that the spleen here was completely shattered. This is how a liver is, this is how the spleen is also supposed to enhance, but it was completely shattered. And by the time we waited for about 24 hours, the fluid around the liver and in the pelvis had significantly increased. The patient had to be wheeled in into the emergency, into the OT with a very low hemoglobin, which could have been avoided had we done the contrast at the very beginning itself and picked up the trauma. So, as I said, quality is not just about the report that you're giving, but deciding which investigation to do so that the patient gets a good quality care is also a part of quality in radiology. Coming to reports, errors and discrepancy in radiology are inevitable, is what they say. It's not unavoidable. Everybody makes these errors. So, what do we need to do is basically look at these errors, do a quality assurance, do audit, and come to what those errors are like and make sure that we don't make these errors anymore. Right? These why are there errors in radiology? Because we have very high volumes usually. We have a wide practice scope. You have to know everything from the head to the foot, toe, ultrasound, till head CT, everything is covered under radiology. We do not focus on only one area. So there's variable complexity as well. There's always time pressure. As I said, we are monitoring turnaround times, which means that we have to generate reports within time pressures. And we are always shortage of juniors because people come, they get trained and they leave. So they result in a situation that has a higher likelihood of committing diagnostic errors. How do we ensure quality then? We make sure that we select and train our juniors accordingly. We maintain standardized reporting templates so that we don't miss anything. We do communication of reports in good time. We have a robust peer review process where we review each other's reports and make sure that any mistakes are corrected. We have a data tracking mechanism. We do the analysis of data and we do discrepancy meetings. So this is a standardized report template where we mention all the organs, and wherever there's something abnormal, we write it. So what it does is it makes sure that you're looking at all organs and not missing out one finding in anything else apart from the very obvious thing which for which the patient has come to the hospital. Okay, then so this is a Swiss cheese model. As I said, there's a peer review. So we make sure that one complex case goes through multiple eyes so that we don't make, so that if there's anything which has not been picked up by the first person is picked up again. We do audit of these reports, and these audits are done where we give them a score, a RADP scoring system, where we say whether we agree with the report, we disagree with the report, but we understand that this is an understandable miss. Either it is clinically significant or not clinically significant. And a three error is an error where we say that this is an error. This should have been diagnosed the error is entirely on the radiologist for not being able to make that diagnosis, either whether it's clinically significant or not clinically significant. We do understand that radiologists can make errors because of lack of under reading, because of improper technique of study, because the prior examination results have not been provided, the history has not been provided. We have seen one imaging finding and we've been so happy that we've picked up the cause of pain that other things we are not seeing, which is called satisfaction of search. Or there are some complications from a procedure which has not been communicated to us. All of these, then we take that into account when we are categorizing our errors to communicate it to our colleagues and juniors. We do peer reviews internally where we look at each other reports. We send out some reports for an external peer review, which is 1% of each modality. This is important from the NABH standard, where reports should be seen by other radiologists who are not working with you so that it can be a very unbiased assessment of the errors. Any discrepancy which has been brought to us by the clinician, we again do a grading on severity and impact on changes in patient management, like the STRAD-PS score I spoke about. We do clinical radiological meetings for correlating imaging findings with clinicians. In these clinical radiological meetings, we anonymize data and we present it. Like here, we've said that there's an acute infarct which has been missed, and we will anonymize the patient data, we anonymize the reporting radiologist, we anonymize everything. We just present the images and any learning point, like we say that look at ADC images and compare with diffusion images just to make sure that you don't miss infarcts. Another case where somebody has reported this as normal, but there's a very tiny infarct which is seen better on altering window. Again, everything is anonymized, but we have a meeting amongst all radiologists so that one error can teach multiple people. Everybody should not make the same errors because every error costs something to another patient on the other side. So we make sure that we do these meetings so that one error can teach multiple people at the same time. And we are able to communicate that everybody should learn from these learning points, where we say advise MRI if infarct is not seen, if patient is not doing well. How do we minimize reporting errors? We reduce variation. We standardize our reporting formats, standardize our machines, standardize the protocols that we follow. We do lifelong learning. We keep having CMEs. When we have students, we have to teach them. We make sure that our juniors are also involved in the teaching program so that they also learn along the way. We do systematic approach of review areas, of checklists. We do structured reporting. We use technology wherever possible. We should clearly and effectively communicate. We do reduction of interruptions and distractions as much as possible, not possible in busy hospitals, but ideally this is what should be happening. And as I said, when we are doing a learning session, it's completely blame free. We do not publish the name of the patient or the name of the reporting radiologist. We just hope that everybody learns from that as well. When we communicate results to clinicians, we do it in a structured format. We use structured reporting so that nothing is missed. We do critical value reporting so that critical things can be communicated immediately. When we have addendums, we have to inform them that we are putting another point. Please note, if there's a report which is completely changed because a senior has thought or some other radiologist has seen a new finding, we recall the report, we delete the report, and we communicate it to the concerned clinician. Because if we do not do that, then just changing the report does not mean that the patient or the clinician would have seen. They might have started treating on the basis of the first report. So if there's a significant change where the diagnosis changes or more findings are added, we make sure that the report is recalled and a new report is given only after communicating with the clinician. We audit, as I said, we audit both the adequacy of the clinical information, whether that is good enough, what is the appropriateness of the procedure, what is the quality of the image, what is the interpretation, is the interpretation and the quality of communication good enough from the radiologist, and what other else should have been done to follow to arrive at the specific diagnosis. These are the points on which we audit, because this is what the quality assurance program in radiology is. Not just the reporting, but also the acquisition of images, whether the imaging modality used was appropriate, whether the history provided was good enough for us to be able to change protocol, and whether it was communicated in a proper manner. The turnaround times are influenced by multiple factors, including the case complexity, study modality, and therefore unforeseen errors can occur sometimes due to PACS downtime. From the radiologist standpoint, diagnostic accuracy supersedes the TAT. So what you realize if its case is very complex, communicate one thing and then make sure that you're giving good report rather than just focusing on giving out a report. And that it has historically been the primary focus. So the good report of a good diagnosis is very important to ensure a good quality radiology department. We have to develop AI technologies and systems which can reduce the burden on the radiologists and completely, so that everything can happen in a streamlined manner. Why is quality important? Because it is the core of patient care. It ensures that it is effective and efficient. You're opened a hospital, patients are coming here, you have to care for them, treat them and send them back. Quality ensures that this is done in an effective manner, in an efficient manner. It leads to better outcomes where the patients are satisfied and can trust you the next time they have to reach out to a hospital again.